Mute the sound though during the presentation?
You mean everybody's mics? Probably so, right?
Yeah. Okay.
Okay, well, let's get started. I know a few people will probably end up joining us as we go, but let's get started. And first, we have the privilege of having Dr. Elissa Hellman with us, and she is an OBGYN, and she's going to get us started tonight. And so how the format's going to work is that we are going to have Dr. Hellman, then Mike Karegeannes, and then Diane Ping each give presentations for us. And we will then open it up to questions afterwards. So without further ado, I will turn it over to Dr. Hellman, and she will get started.
All right. Hi, everyone. My name is Elissa Hellman. I am an OBGYN at Meadowview OBGYN, which is the Ascension Columbia St. Mary's office in Ozaki. And I'm really happy to be talking to you guys about pap smears today. It's pretty much like the bread and butter of what I do every day. And I find that women aren't really sure like what exactly it is. It's not a test that you're watching us do, and it may just be kind of this little vague GYN procedure that we're doing. So I just kind of wanted to make it a little bit more clear for everyone. So I'm going to share my screen. Hopefully it will work. One sec. There we go. Okay. So this talk is basically entitled Pap Smears 101. So hopefully easy to understand. So let's get started with what is a pap smear. And literally it is a smear of cervical cells on a microscope slide. And just like you would smear or schmear a like cream cheese on a bagel, that's pretty much exactly what it is. It's a screening test that's used for cervical cancer. And it was kind of made by a Greek doctor named George Papanicolaou. So that's where the word pap comes from. It's like a shortened version of his name. And with a lot of other scientists, he kind of realized that you could take cervical or vaginal fluid, put it on the slide, and actually study the cells and learn a lot of things about what's going on inside. So PAPs get a really bad rep. I get that it's uncomfortable. It's not everyone's favorite test, but it's really not that bad. It's quicker than a mammogram. You don't need sedation like a colonoscopy, and it's super important. So hopefully this will kind of help people understand that it's not the worst thing in the world. All right, so before we kind of go into actually like about the pap smear, just a really quick anatomy review of female anatomy. Here is the vagina. When you look inside the vagina, you can see the cervix. The cervix is the lower part of the uterus. This is the uterus. There are two fallopian tubes that connect to the side of it. The fallopian tubes kind of hug the ovaries that they're next to, and that's pretty basic female anatomy. Then this picture up here is the gynecologist's view. So this is a gynecologist between a patient's legs with a spiculum inside the vagina looking at the cervix. And it basically looks like a donut. And then this is a view of the cervix cut in half where you can see the outside of it and then the inside of it. And this is a little picture of a brush inside of it, just so you kind of see like how long it is. And then this is another view of the actual body cut in half. We see the bladder up here, the rectum down here, and the vagina is in the middle. So again, spiculum in the vagina, pap smear instrument touching the cervix. All right, so as a doctor collecting the cells, I don't actually do the smearing. I pretty much just do the collection. Can you guys hear me still? Yeah?
Yep.
Okay. endocervical cells, and the external, the ectocervical cells. And this brush here, this little pointy part, sits in the opening, that little hole in the middle of the cervix. You twist it around, and the longer bristles get the internal cells, and the shorter bristles get the external cells. And then they're put in this vial of fluid, swished around, and then that vial of fluid gets sent to the lab and gets read by what's called a cytopathologist. A cytopathologist is a pathologist who specializes in the study of cells, which is what cyto means. You can also use these types of brushes. You have to use both of them. The smoother edge spatula gets twisted around to collect the outside cells, and then the bristly brush gets inserted into the cervical canal to collect the internal cells. And it's basically collecting all that mucus and fluid from the cervix. On this fluid can also be, you can do tests on it looking for a lot of STDs like HPV, chlamydia, gonorrhea, and trichomonas. So by this funny little meme, which I love putting into my presentations, it's hopefully not too sexist, but I thought it was funny and pretty tame as pap smear jokes go, and kind of appropriate for Wisconsin. Someone from the gynecologist called, they said pap smear is normal. I didn't even know you liked beer. All right. So now that we kind of went through like what the gynecologist does in the office, let's kind of go now to, well, how does this carry over into what the pathologist sees under the microscope? So the top two pictures here are cartoons and drawings. The bottom two pictures are actual pictures from a microscope slide. So they are looking at a lot of different things. Number one, the size of the cells. So these are all cervical cells. So normal cells, they're all pretty uniform in size. Abnormal cells, lots of variation. How many cells are there? So this is just a really small section of a slide, but there's generally going to be a lot more cells when they're abnormal. Looking at the nuclei, so if we remember back to 5th, 6th grade biology, we remember the nucleus is the kind of controlling center of the cell that makes it grow and replicate, and normal cells really should only have one. Abnormal cells can have multiple ones and different sizes. So that gets to the proportion of cell size to nucleus size. Normal cells, again, things look much more uniform and proportional, as opposed to abnormal cells, which you can get lots of different cell sizes, nucleus sizes, any combination. And then clumping. We see a lot more clumping when they're abnormal, as you can see right here in the bottom of the picture slides, this big, huge clump of pretty abnormal cervical cells. And then this is, you know, we learned that cells make up tissues. And this is a graphic that kind of shows how does it translate from cervical cells, looking at those on a slide, to what does it look like from the cervical tissue perspective. And these top two rows are drawings. The bottom is actual pictures under a microscope that a pathologist would look at. And we can see that as things get more and more and more abnormal and progress to very like precancer or cancerous cells, the cells look much more disorganized, disordered, not the same. And that's basically what cancer is, just cells out of control without any type of growth regulation. All right. So you had your PAP, and then what? So you had your PAP and you get normal results, great, come back whenever your gynecologist tells you for your next test. But if it's abnormal, so the reason we do screening tests are to identify the people who need diagnostic tests. A diagnostic test of someone who's had an abnormal PAP is called a colposcopy. Colpo means cervix, scopy means looking at, so this is basically a test that's called looking at the cervix. Based on the results of a colposcopy, which is more of a tissue sample rather than a cellular sample, that determines the treatment. So the treatment is mostly removing the abnormal cells. That can be done in many different ways. This is totally out of the scope of a PAP talk, but basically either removing that part of the cervix or a complete hysterectomy. All right, one more little humor break with the election coming up. I thought this would be appropriate aside from the strange looking animal. I'm tired of smear campaigns that don't have PAP in front of them. All right, so let's get to why we do pap smears at all. So what are we trying to prevent? And we're basically trying to prevent getting to the point of cervical cancer. We're trying to treat it before it gets there. So what causes cervical cancer? The top million answers are HPV. HPV stands for human papillomavirus. It is the cause of many types of both genital, oral, and anal cancers. We don't have to use our imagination to figure out the connection between the two that much, but that's pretty much what it is. There are very, very few cervical cancers, like less than 1%, cervical cancers that are not caused by HPV. The other reasons may be a genetic predisposition to cancer overall due to some other mutation, metastasis from other cancers in the area, and a few other things that are extremely rare. So HPV, again, stands for human papillomavirus. It's the most common cause of, like I said before, genital, oral, and anal cancers. And basically the virus is found on the tissue surface and in the body fluids and secretions. There are 150 different strains. That's a lot. There's high-risk strains and low-risk strains. So the high-risk strains are the ones we care about a little bit more. They're the ones that cause cancer. And the low-risk strains, even though they're not, what they cause are not great, but they basically cause genital warts, which though are a little bit icky, I mean, they're not cancerous. And this is crazy. By age 50, 80% of women will have had an HPV infection in their life or have had it in the past. That's a lot of women. So how do you get it? Basically, you need two individuals, doesn't matter the gender, and they have some sort of sexual activity. One person infects the other. You can get infected with any of the strains. This graphic, by the way, is actually from Canada, as I'm seeing here. Some of it is not entirely accurate, but the picture is nice. And it just tells you what type of strains may be responsible for which types of cancers more frequently. At the bottom here, it says low-risk strains, like the ones that cause genital warts. Your body can clear the infection. Your body can actually clear even high-risk strains. So that is just something that also to keep in mind, because that's encouraging. Did I want to say anything else? Okay. By the when I said this, by age 50, 80% of women will have had or had it. If they have had it, that means that their body has cleared it. So it's kind of like not a big worry anymore. So I don't want, I just want people to understand that. All right. So what's the bad news about cervical cancer? It's a really bad cancer. It's definitely not one I would pick to have. It spreads, once it's spread and once it's kind of invaded into the cervical tissues and the tissues around it, top of the vagina, the uterus, it is extremely hard to treat. A hysterectomy does not cure you. Women end up needing radiation, sometimes chemotherapy, and those are extremely hard treatments to go through. It used to be the most common cause of cancer deaths in American women. It's usually diagnosed between ages 30 and 50. Those are extremely young. Imagine like a 35-year-old woman with 3 little kids at home having this horrible cervical cancer. I mean, their chance of survival is very low, and has a really high mortality rate, like I said before, about 50 to 80%, depending on when it's caught and what kinds of treatments are used. And then, so when we talk about the risk factors for cervical cancer, they're really grouped into kind of 2 categories. One is behavioral risk factors, and the other are your immune state risk factors. So behavioral are things like smoking. So you smoke, which actually is kind of connected to a decreased immune system. HPV infection during sexual activity, history of having lots of other STDs, and it's not saying that if you have other STDs, you will get cervical cancer. It's just the more someone is exposed to infections overall, the higher the chance HPV could be one of them. Also, the more lifetime sexual partners you have, the higher that risk goes up, and a low vitamin diet. So that also gets to your immune system, because vitamins are great for your immune system. And any conditions like HIV or sometimes autoimmune diseases or being on chronic steroids, those may weaken your immune system, thereby causing your risk for HPV infection to be higher. So, but there's also really good news about it. I mean, it is super easy to detect in the early stages. I mean, if we compare to ovarian cancer, which is so hard to detect in early stages, this is really good news. It's also really easy to treat when we detect it in the early stages, either simple hysterectomy or that LEAP procedure I had on a previous slide. That can cure you. It's also really easy to access, right? Like, I can see your cervix, I can't see your ovary, I can't see your uterus, even your breast tissue you can't really see. So all I need to do is take a look, and I can kind of tell based on what your cervix looks like, or a little test, if something's going on. And it's also really easy to reduce your risk. So just some pictures here. I mean, eat the rainbow. Tons of antioxidants, tons of great vitamins will help boost your immune system, literally fight cancer cells. Stop smoking, that will also make your immune system stronger. Condom use can help, not completely, but it does reduce the surface area of skin that is in contact with someone else who may have HPV. And then the HPV vaccine, which I'll get to briefly a little bit later. All right, some other statistics. Cervical cancer has dropped more than 50% over the past 30 years. I'm going to say that again. Cervical cancer has dropped more than 50% over the past 30 years. That is incredible. No, we've not been able to do this with any other type of cancer for such a huge drop in such a short amount of time. So why is this? Sorry, my graph here is not perfect, but we have much better screening, right? Since the Pap test, we've been able to screen a lot more women. We also have a much better understanding of what causes cervical cancer now that we have an understanding of HPV, and a lot better PR. So women's health is definitely more on the radar in the past 30 years than it really ever has been. So women, I think, are more willing and have more of an understanding that they have to get checked out and have screening tests. And then also the HPV vaccine has definitely contributed to this huge drop. So I don't want to get, into a big vaccine talk, but I have to mention what the HPV vaccine is and what it does. So currently what we give is what's called the Gardasil 9. There are a few other ones out there, but this is the one that we give in America and is the most comprehensive. So it covers 9 strains of HPV, 7 of which are high risk, meaning cause cervical cancer, and 2 are low risk, meaning cause genital warts. This came about in 2014. Prior to that, since 2006, Gardasil 4 is what we were using, and it covered 2 high-risk strains and 2 low-risk strains. The goal is to vaccinate children before sexual activity starts. So your pediatrician probably will start talking to you about it for your children between around ages 11, 12. It is approved between ages 9 and 45. It used to only be approved age 9 to 26, and now that has changed recently. And that was purely, it's not that it was bad in people who were older, it was more just a insurance coverage situation and who the actual studies were done on. But it is now up to age 45. And it's for boys and girls, not just girls because they have a cervix. But remember, HPV also causes genital cancer, anal, penis cancer, anus cancer, oral cancers, and boys can get those. And boys are also, it takes 2 people to have sex with each other. And so since boys are involved in that, it can decrease the exposure that people have overall. It's either 2 or 3 injections. It's 2 injections if you're under age 15. It's 3 injections if you're over age 15. And that's because you create and mount a better immune response the younger that you are. All right, and this is just a little graphic kind of going over some really great statistics. All right, so if I haven't convinced you that you need a pap smear and you should get them and they're important, I'll let Ryan Gosling do it for me. All right. So just to kind of briefly wrap up, I just want to kind of mention guidelines. This is probably one of the most confusing parts of pap smears, both for doctors and for patients, because it's their guidelines. There's no rules. There's no one telling me this is what you have to do and just make it simple. So they give out these guidelines, and we just have to kind of use our best judgment. But the things that we have to kind of consider regarding them are some of these here. So who makes these guidelines? Why do they change? We're learning so much new information so fast, and that's kind of why they do change. Who do I listen to? When do I start getting PAPs? Probably age 21, maybe it's age 25. Is it 18? Is it when you start having sex? Who knows? How often do I need them? Generally 1, 3, or every 5 years. When can I stop getting them? Probably between ages 65 and 70. Can I get them more frequently than recommended? You can, you don't need to. Can I get them less frequently than recommended? Sure, but you probably shouldn't. Do I need an HPV test also? Yes, that will actually help us determine how often you need them. You don't have to. Can I only get an HPV test? Yeah, like the newer guidelines, which I'll briefly mention, sure, maybe you can. And is there any harm to getting a pap test? There's no harm in the actual pap test. It may be a little uncomfortable. You may have a little bit of spotting or bleeding, but the pap test itself isn't harmful. What could be harmful, though, is if you are doing too many inappropriate pap smears, that you start getting results where maybe you'd have to do procedures, and maybe those procedures aren't necessary, because if you just waited a little bit, things would get better. And are there exceptions to the rules? Of course, there's always exceptions to the rules. That is why these are guidelines and not rules. So this is just a little timeline down here of when we get all of our main algorithms that we use of who to test, when to test, what do we do if there's an abnormal test. And very recently this year, there have been some changes that focus much more on just HPV testing and really minimize the amount of pap smears and actual cellular studies that we're doing. I'll tell you, the gynecology societies that we kind of follow, that ACOG and the ASCCP, we are a little bit uncomfortable with it, maybe because we're just so used to doing pap smears, but we have found that when we told people, get PAPs every year, oh wait, no, get them every 3 years, people didn't come to the gynecologist anymore. They were missing out on their annual exams because they thought, hey, I don't need my PAP anymore. So we are a little bit hesitant to say, hey, you know what, you don't really need this test anymore. Let's just do these random HPV tests less frequently. And that's enough for PAPs, for cervical cancer screening. So we're still kind of back in the 2018 algorithm right now, but who knows what will happen in the next few years. So as far as the cytology, HPV alone, or cytology and HPV decision, all of these organizations are really who help make up the rules. So the American Cancer Society, the Preventative Task Service Force, the ACOG, and the GYN oncologist, and the the ASCCP that I just mentioned is really kind of like the go-to of who we listen to. All right, very brief overview. So start them at age 21. The newer guidelines say maybe at age 25. Cytology, meaning the pap smear slide, every 1 to 3 years, 1 or 3 years. With HPV co-testing, you can either do just HPV co-testing, because if you have a negative HPV, you probably have a normal pap, not always though. Either alone or every 3 years or every 5 years. Stop them between age 65 and 70. But if you have an abnormal PAP, your timeline will totally change and you're off of this algorithm. Insurances still do cover PAPs yearly, so if anyone's concerned about that. And remember, your annual exam really is not just a PAP smear. We do so many other things during the annual exam, breast exam, pelvic exam, and really just kind of making sure that everything else from a GYN perspective is tuned up and it's not just the screening test. All right, so for a little bit of nerdy fun at the end, we'll see other little pictures of what you can see on a pap smear slide. So top corner here, yeast. These long stringy things here are called hyphae. That's like if someone has a bad yeast infection, we can see that in their the cervical mucus that's collected. Trichomonas, this little red thing here with a tail, that's actually a parasitic STD. Easily treated. And then here, if you've had sex a day or two before coming in for your pap smear, we can probably see the sperm that's still alive and floating around on your pap smear. Very rarely can we see like uterine cancer or vaginal cancer cells that have kind of come down out of the uterus or kind of sloughed off in the vagina that get included in that cervical like mucus and fluid specimen. Last slide, very common questions. Can you get a PAP during your period? Yes, you can. Definitely you can get a PAP during your period. You don't have to cancel your exam if you have your period. They are able to wash away the blood from the fluid that it's collected in and then just look at the cervical cells. Will it hurt? It may be uncomfortable for a little bit, but the actual brush itself that collects the cells probably isn't what's uncomfortable. It's mostly the speculum in the vagina that's a little annoying. You're in a long-term monogamous relationship. Do you need PAPs? Yes. I'm sure we've heard the when you sleep with someone, you're sleeping with everyone else they've ever slept with, a little phrase. So you never know, you could be totally monogamous, but someone they have had a sexual partner with in the past has exposed them to HPV. You've had a hysterectomy. Do you need pap smears? So number one, with the hysterectomy, most of the time the cervix is included in the removal, but you just want to always make sure. So if that cervix was taken out with the uterus, do you need a pap? Probably not. If it was removed for malignant reasons, uterine cancer, vaginal cancer, cervical cancer, yes, you still need PAPs just in case some cancer cells have spread into the vagina, and you can actually do a vaginal PAP to detect if there's any cancer cells that were left behind that can be detected on that fluid and from that brush. All right, the most common question we get in the GYN office regarding PAPs and ER visits, I had an exam. I for sure had my PAP. No, never, ever, ever. You never had a PAP in the ER. That's like walking into the ER with chest pain and getting a mammogram, or walking into the ER with abdominal pain and getting a colonoscopy looking for colon cancer. Never happened. You may have had an exam with other tests, never a PAP. Okay, I think that is it. So I just really want to thank Freedom Physical Therapy for asking me to do this talk, something I'm really excited to talk about. And this is where my office is, my office number. If anyone ever has any questions or wants to make an appointment, here it is. All right, that is it.
I love the at your cervix. That's adorable.
Thank you.
Dr. Hellman.
No problem.
Okay, Mike, you are up next.
Let's see if I can figure this out. Yes, Dr. Hellman, that was fantastic. Thank you. I just had one question, and I know that's not really question and answer time, but having two daughters, and of course, lots of female clients I treat, how do you convince those that don't seem to want to get the HPV vaccine?
That's a good question, a very hard question. You know, I don't like to ever force people to get something that they don't want. But I think the goal is really to kind of tease out, like, why don't you want your daughter to get it? Are you nervous it's going to make them promiscuous in some way? Are you worried about side effects of the vaccine? Like, what is the issue preventing you from wanting to get it? And then kind of just giving some education about, well, really, we haven't seen any horrible side effects from from the HPV vaccine, and also going over everything I just did and saying cervical cancer is horrible. You don't want your daughter getting this. And not only cervical cancer, it's not always about cancer as the end result. It's about some of these treatments for pre-cancer can have pretty bad obstetric implications. And when you're trying to have babies and your cervix is now kind of, it's been operated on and it's not ideal, or there's problems holding a baby in for the term of a pregnancy. So sometimes kind of going into detail of things like that makes parents think, oh, wow, you know what, like maybe it's more than just a shot about for an STD. It's also about like what potentially my daughter or son could be exposed to down the road, and the difficulties they may have that we could have prevented from a couple of shots, just like they're getting all their other shots.
Yeah, no, I hear you. That sounds good. And maybe I missed it. So HPV, obviously a big contributor to cervical cancer, ovarian as well, or not so much?
No, not ovarian cancer is not related to a virus as far as we know. Ovarian cancer is more related to either a genetic predisposition or a few other risk factors that have to do with periods and menopause and pregnancies, but definitely not a virus as far as we know.
Gotcha.
Did I miss the age of which you don't have to worry about that, or is it when you don't have sex, or
It's usually between ages 65 and 70.
for both the HPV and the Pap smears?
Correct.
Oh, so even
Yeah.
older, because I was never even offered an HPV vaccine, and I'm 73.
Oh, no. So the HPV vaccine is only given up to age 45.
Oh, 45. Okay, I knew I missed that. Okay,
Yeah.
all right. And why is that?
So the thought behind that is probably around that age, you are generally more on the monogamous side. And the chances of you getting HPV are much lower. And from time of HPV infection to time of cancer development can be like between 10 and 20 years.
Oh,
So they think that there's just the time frame of the disease developing. That's where they kind of came up with that age. Also, the studies are only done up to age 45, so they can't legally recommend someone older than it was studied in. Like, they're not going to get their FDA approval if they give it to some people older.
and so, because I have 3 granddaughters, and I remember nurses talking about it when they had their daughters turn to be, preteen and teenagers, about
Right.
getting the HPV virus. And it's just something I had
Right.
never heard of before.
Yeah. It's out
Dr.
there.
Hellman, I have a quick question for you. The higher risk HPV strands, those are typically asymptomatic, right? Or are there any symptoms associated?
Right, so there's very few symptoms. Usually we detect it because we either do the pap smear or we can see a lesion. Like when I'm looking at a cervix, I can see a lesion. Symptoms would be, though, if you have a lot of bleeding, just kind of random bleeding, often associated during intercourse when the cervix is kind of being moved, that can kind of trigger bleeding, or if someone like feels a mass. I mean, that would be advanced cancer already, but there's very, very few symptoms at all, and that's why we do those screening tests.
Okay. And then do you ever find endometrial tissue on a pap smear? If can you pick that up at all?
Yeah, so we can. Most of the time, there's really no concern for it. If someone has their period and they're actually sloughing that endometrial tissue, we can. Usually the pathology report will say, oh, we see endometrial cells just clinically correlate with, is this person currently on their period? And if it is, then we kind of know that it's probably fine. It was just their period. Every so often, if they see those cells and they say, hey, these look kind of high grade or suspicious, that would require then a follow-up test looking at the inside of the uterus on top of a cervical diagnostic test as well. It's pretty rare, but it does happen.
Okay, thank you.
Sure.
Okay, shall we proceed? At least I hope I can figure this out as well as you did, Dr. Hellman. You seem pretty effortless with this. Let's see here.
I had a tutorial for Molly.
Oh, you did. All right, that's good. Let me
Share
see.
screen on the bottom.
Okay. Yep. Let's see here. Whoop, what is that? Got to get rid of that. And remove screen share. Stop doing. Okay. Sorry. Hang on. All right. Can people see that? Or no? No, Molly? No?
No.
Huh. All right. Hang on. Share screen. How about now?
It is just starting. Yep.
Yeah. Okay. All righty. So thank you all for obviously being here tonight and giving up a good hour plus of your evening. And Molly, Nina, and Diane, thank all of you for taking the time to put this together. I feel very fortunate to work with such amazing women who are smart and intelligent and humorous and, ultimately very passionate about what they're teaching and sharing. And I know how they, how well they take care of our patients. So for me tonight, I am going to be, let's see if this is going to work. Are you going to go to the next slide here? Or are you going to give me difficulty? There we go. My mission tonight with you is to kind of share a little bit about, the menstrual migraine, a little introduction just to migraines in general, but then just, given more of a women's health topic. To share some information on this. As some of you probably know, one of the things I feel we do very well at Freedom is we're big into sort of temporomandibular disorders, which lends itself to a lot of oral-facial pain issues, headaches, migraines, and of course neck pain. So not uncommon that we see a fair amount of women and men, of course, but more common in women dealing with, either chronic headaches, daily headaches, or migraines, and then of course the menstrual migraine. So if you get a headache just before or during the first few days of your menstrual period, you may have menstrual migraines or menstrual related migraines. So what makes a headache a migraine? So a migraine without aura. So that means you get at least 5 headache attacks that can last anywhere from 4 to 72 hours. It tends to be one-sided pulsating pain of moderate to severe intensity, aggravated by or causing avoidance of routine or physical activity. So it's not uncommon that, for better or for worse, sadly, if someone does have a scheduled appointment, they tend to cancel because they almost really can't function, or they need to go into a quiet room or a dark room, certainly can't drive unless they have someone to bring them. And then accompanied by at least one of the following symptoms: nausea or vomiting, photophobia, so hypersensitivity to or avoidance of light, phonophobia, hypersensitivity to or avoidance of sound. Now, migraine with aura, a little bit more, involved and certainly a little scarier in the sense that you'll have at least one of the following, however they do resolve completely. So visual symptoms, maybe flickering lights, spots, lines, or vision loss. Sensory symptoms, for example, pins and needles or numbness, and then speech disturbances. So maybe putting some words together. So what can be some of the symptoms you might have with a migraine, right? Anything from, blurred vision, fever, loss of appetite, pale skin, fatigue, sensitivity to light, smells, or noise. Many of our clients have, sensitivity to chemical smells, all those different types of things that you need to even consider as a clinician so that they're not offensive or possibly even a trigger to your patients that are sensitive to smells and that type of thing. We talk a lot about the timeline of a migraine attack. So you can kind of have a prodrome, which can come a few days or hours before. And then of course the aura can last anywhere from 5 to 60 minutes. And then primary type of headache, 4 to 72. And then, it can linger for the next day or two following. So, and again, before or during a feeling of feeling well, a feeling of well-being or a surge of energy, talkativeness, restlessness, increased appetite, drowsiness or depression, irritability or tension. And then during the attack, can be quite uncomfortable: nausea, vomiting, diarrhea, sweating, cold hands, many of the things we talked about before. Scalp tenderness or pressure. I mean, that's always a interesting one. You know, patients ask all the time, you know, when you're working on their neck and their head and their facial area, like, boy, my scalp is super sensitive, or I can't wear a ponytail. And you know, the response I at least tend to share with them, or at least my belief is, you know, around our skull are the meninges. Yeah, so and given the central nervous system can get significantly impacted by a migraine, it's not uncommon that the meninges of the skull become sensitized and the scalp can be tender. So what's a menstrual migraine? Migraine is a chronic disorder of the nervous system that results in recurrent headaches with other symptoms, as we talked about in the prior slide. It's amazing, 30 million Americans, 12% of people between 12 years and older. And as we talked about, it can occur with or without an aura. A pure menstrual migraine and menstrual-related migraine are migraines without aura, as we talked about earlier. The attacks can occur about 2 days prior or during the first 3 days of menstruation in at least 2 of every 3 consecutive menstrual cycles. In pure menstrual migraine attacks, they don't occur at any other time of the month. So that'll be the difference between a pure menstrual migraine versus a menstrual-related migraine, which can occur with your menses or at any other time of the month. So again, not uncommon that clients are experiencing things sometimes a few days before, which is why we'll talk about a little bit later. You want them to try to log this so that maybe we can try to be effective with doing things a few days prior from their cycle to either reduce the severity or, if we're lucky, you know, alleviate if possible. Some research has shown that the severity of headache, pain, and other migraine symptoms, as well as the level of disability related to an attack, may be increased at menses. In addition, the frequency of headache attacks appears to increase at menstruation. Migraine attacks at menses may be more persistent and difficult to treat because pain may return even with treatment. So, you know, for the women that I treat with this, I mean, that tends to be the situation. You know, I feel like we've had good success at, you know, I try to explain to them there's so many different triggers here. You are possibly someone with neck-related pain, certainly, potentially daily headaches, tend to find a lot of pain and dysfunction in the muscles of mastication and around the face, and maybe some temporomandibular disorders. And if you can work hard to reduce those other things that create pain and sensitize the central nervous system, you can have a real impact on those, and even in reducing the migraines that tend to happen throughout the month. But the more challenging ones have continued to be when the menstrual cycle hits. You know, sometimes it's been a real challenge to obviously alleviate that or reduce it. Why do I get headaches when I have my period? So the migraine appears to have a strong hormonal component. The condition is nearly 3 times more common among women than men, occurring in about 18% of the women over their lifetimes and about 6% in men. In addition, most women with migraines, so nearly 80%, first experience an attack between the ages of 10 and 39, when the estrogen levels are highest. Prior to puberty, girls and boys have migraines at an equal rate of about 4%. So while the number of males with migraine increases slightly as boys age, the number of females with migraines increases dramatically, of course, accounting for the higher overall lifetime occurrence for migraines in women. So a pretty big preponderance. And you know, it's interesting because when it comes to temporomandibular disorders, you see a similar thing. The ratio of women to men can be 2 to 1 and as high as 9 to 1. And some of the other comorbidities that tend to occur with women who have migraines, jaw pain, abdominal pain, back pain, it's a challenge, and they're not feeling well, and it's very unfortunate. So here we have the menstrual migraine and or the menstrual related migraine. With the menstrual migraine and menstrual related migraine are common among women who have migraine. Approximately 15% of female sufferers have a menstrual related migraine, while maybe 4 to 12% have just pure menstrual migraine, which again only occurs during their period. In these conditions, headache attacks are caused in part by a drop in the estrogen levels, as we just discussed before. And it appears that estrogen may help protect women with menstrual migraines and or menstrual-related migraines. So the rapid drop in estrogen levels that occurs leaves women more vulnerable to an attack. So it's interesting because, and this is the feedback, again, I consistently sort of get from our female clients, changing estrogen levels throughout a woman's life also appear to affect a migraine. So for example, the frequency of migraine attacks have been shown to decrease through pregnancy to a low in the third trimester when estrogen levels are highest. Interesting, like my wife used to suffer from endometriosis, and she loved being pregnant with our 3 kids because by the third trimester she felt fantastic. It's the first time in a long time she wouldn't have either abdominal pain or back pain. So again, very similar situation we're seeing here. Frequency increases to normal in most women after they deliver as estrogen levels return to pre-pregnancy levels, although it may stay lower if they're breastfeeding for a period of time. So migraine is also less common following menopause when estrogen levels decline but remain steady. So is it treatable? Yes, menstrual migraines and menstrual-related migraines are treatable conditions. There are several treatment options available. So make sure you consult with your healthcare professional, right? Whether it's your primary doc, your OBGYN that you're communicating with, maybe your physical therapist, chiropractor, massage person. I'm not sure who everybody likes to see and use, but if they have some knowledge in this or can point you in the right direction, there are things that can be done. Lifestyle modification can be a big one. It's the first element. Learn how to identify and avoid possible triggers, right? So reduce stress, maybe adopt a healthier lifestyle if you don't currently have one. Really work hard to figure out the predictability of when your period is going to occur and how you can maybe reduce the intensity of it as it comes around. But then at the same time, right, try to resist the urge to prepare by getting it all done. So sometimes I find, during our course of treatment with our clients, you sort of have to help map them out a strategy and a plan because it's overwhelming. There's no question. So doing the best you can to say, hey, this could be, for some of the women I see, I have a client right now. We just celebrated our first year together, but she was having 20 migraine attacks a year. She's down to 5 or a month. She's down to 5 a month, and her daily headaches are gone. The challenging one continues to be that time of month for her. But the point is, her quality of life, she's back to writing her books and is significantly up, but obviously not 100% resolved. But she has followed a lot of the advice that we're talking about today. So, identifying and avoiding common triggers. So, and I always hate the word diet because it always sounds like, we're all trying to lose weight. So kind of nutritional things to consider, right? Alcohol, some various foods like cheeses, processed meats, chocolate, red wine. Caffeine can be a big one. Certain medications, including the abuse or overuse of over-the-counter analgesics and triptans. And then environmental situations, as weather effect or barometric pressure, smoke, perfume, odors, bright lights. All of these things can be triggers. So that's why too, even as a clinician, we have a pretty busy, crazy orthopedic practice at all of our locations. So that's why for us sometimes with the private rooms we can try to control the light, control the sound, maybe pipe in some more relaxing music, things that are more pleasant, have a blanket available if you're cold, anything that we can do to try and make the experience better and not be a trigger. And then I talk a ton about internal factors like anxiety. I always say, even when I lecture now, I feel like I spend more of my time managing and treating anxiety for people because it's a big issue. They've either been mistreated in the past or they've seen multiple providers with not such great outcomes, or maybe just not feeling heard. I mean, I do think that's a big one, that it's all in their head or there's something else going on when clearly there's a lot of other issues that are contributing to this. And dealing with any anger, fear, depression, stress, etc. So how to adopt a healthy lifestyle, right? So start to eat regular, healthy meals, keep well hydrated is a big one. a regular sleep schedule. We don't have time to talk about this, but one of the things I spend a great deal of time is assessing sleep disordered breathing, airway, and all of those contributions that can lead to just not feeling well, having myofascial pain, headaches, all the things that just poor sleep contributes to. Trying to stay regular with your schedule, exercise for sure, aerobic activity, all those things are good to stay healthy and well. Having to rest during a migraine attack when it's appropriate, and then trying to do the best you can to reduce your stress, which, let's face it, during COVID has been quite a challenge for all of us. Obviously, I'm going to spend more time talking about non-pharmacological treatment options, since we can't administer medications, but obviously know that medications are an option. But, things like, obviously, physical therapy, occupational therapy, the laying out of hands, the ability to work on all the various triggers, the cervical spine, the facial area, postural correction, strengthening exercises. There's a lot of great research on how weak people's neck muscles are in front and in back that have contributed to chronic neck issues, chronic headache, that type of thing. The real challenge, which is always intriguing, right, is if people have headaches, they will still come in for their visit usually. But when people have migraines, because it's so debilitating, they really can't even get into the clinic. So it tends to be a problem, because usually people with migraines, when they come to see us, they're feeling okay. So we always, like it, if at all possible, they can actually come when they're flared, so we can experience it and see the reaction of their body and what's happening when they're in a full-blown migraine, but that's not easy. And again, we work closely with chiropractors, and I think manipulation therapy can be very effective. Again, more to treat things like the cervical spine that we know are contributors to headaches. Craniosacral therapy. Not everybody loves deep pressure work and manipulation. So wonderful light therapeutic touch can be fantastic for people to quiet the nervous system. Relaxation training, biofeedback. I'm a big fan of cognitive behavioral therapy and management for these things. And then whether you love acupuncture or dry needling, obviously we both use the same tool, but the science and philosophy is different, but both can be highly effective. And then good nutritional supplementation like magnesium and some other things, and maybe just some good wellness things like massage periodically to take care of yourself. So in addition, menstrual migraines may be treated with acute and preventative medications. As with other types of migraines, FDA-approved pharmacologic treatment options include acute medications, triptans, combinations of other medications, maybe some beta blockers, anticonvulsants. A big one right now is the use of CPRG, which is, again, too much to cover with this topic, but there's been some significant improvement with medications that block certain receptors or chemical irritants in the brain that a few of my clients are on and are doing very well with that as well. So I already talked a little bit about some additional treatments, because I don't want to, I'm probably going over at this point, but anything we can do to kind of keep tabs on short-term prevention, finding out a couple days before the period what can be done to help with these situations. Maybe it is taking some basic over-the-counter medications to help, or again, magnesium nutritional supplements that can help. And then possibly hormonal therapy is something to consider, but it hasn't shown a great amount of promise. Taking daily hormonal therapy can help regulate estrogen levels. Hormonal contraceptives that decrease the number of menstrual periods per year are an option. But it's important to note, however, that hormonal therapy does not completely eliminate migraines. And in some cases, people might get, women might get worse or have more attacks. A headache diary, is something that is very helpful, and a lot of my clients will do, so that they can track all the numerous things over the course of maybe 3 months, such as, when are the attacks occurring? What's the severity? What's the duration? What treatments did you take that maybe helped or didn't help? What was your response? Certainly, your menstruation. It'd be fun to talk with Dr. Hellman at some point down the road about the IUD. I have had some women who I think it's Marina. I'm blanking out on the exact brand. And again, hard to know if it's coincidence or not, but have had some women, when they took the IUD out, their migraines significantly reduced. And then just knowing any other possible exposures or triggers, that type of thing. So what are some, closing tips here, right? So try to eat regular, well-balanced meals. Try to avoid any foods that you think are triggers, maybe an anti-inflammatory diet, that type of thing. Red wine, caffeine. Really work on your sleep. Sleep is crucial. Stress reduction, maybe learn something like heart math or some of these other things that are out there to really help down-regulate the nervous system so that you can feel better. Learn more about the migraine and how to manage it. Talk to your healthcare professional. There's some awesome websites out there, the Migraine Foundation. If you need any of those, or for any friends or family, let me know. Keep a diary. Make appointments with your healthcare professionals, and by all means, keep them. This is not something that's probably going to go away or clear up in 2 or 3 visits. This could be a 6, 12, 18-month plan, especially for the people I'm seeing with 15, 20 years of this. Is not going to go away in a couple visits. And then just make sure, you're a participant in your treatment and an advocate for your healthcare, because there's no question with the way healthcare is going, it is hard to find time to work with clinicians that will spend time with you. So as a quick aside, here's my lovely family. So I certainly appreciate, by having 2 daughters, Grace and Ava, and my wife, having 3 females in my family, the challenges that women, have to deal with. Not that us men don't either, but this is Women's Night. So, but I feel very fortunate that they're all very healthy, and just, I certainly can empathize and appreciate with the challenges that that women have to contend with on multiple levels. And so often it seems so much, the ramifications seem to be more traumatic for women than men. So thank you, be healthy and well, and really appreciate all of you allowing me to share this information, and probably talk too long. So thank you.
Thanks, Mike.
Yep.
Okay, Diane.
Stop sharing, right? There we go.
Oh. Hold on, there we go. Can you hear us, Diane?
I can hear you.
Perfect, okay. You are up and ready to go.
Okay. All right. Hi, everyone. It's nice to join you here tonight. Osteoporosis is the topic for now. This cute little slide here has a couple little risk factors. Just if we can take a look, there's some smoking, lifestyle here is in here, diet, weight, I think, spine, right, aching pain, here's smoking. So these are just some different facts that we'll be hitting as we go through today. Osteoporosis, it's a reduction in bone mass. It's going to cause the bones to be fragile and fracture easily. Peak bone mass is a genetic potential, basically. It's the maximum bone mass that you might accumulate through your life. 95% of it is reached by age 19. And at 30 years, we begin to lose bone mass. So what this means is actually that if we don't reach our genetic potential in our early teens and by 19, there's a greater chance of having reduced bone mass to the point of osteoporosis as we age, just through regular age-related loss. So it's actually a pediatric disease that winds up manifesting in adulthood. 3 factors that influence the peak bone mass are nutrition, heredity, and exercise. Some people look at this information and they see that 60 to 70% and they start to get a little, maybe like they start to worry, like there's nothing really that I can do about this. But I guess as a therapist, looking at that, I see a possible 40% of influence, which is a lot that you can do with that. So let's keep that in mind as we move through. So the most common fractures are a wrist fracture, which is basically like a warning sign. It's time to definitely get the bone density test. The hip fractures, these are very common as well. However, they are very serious, life-threatening. They're commonly from a fall backwards. 50% of the women with hip fractures will die within 1 year of fracture. These statistics do not get prettier. They're for men, actually. The mortality rate is even higher for men. Vertebral bodies are also a common fracture, and these are actually the first bones to show signs of osteoporosis. The common mechanism for a fracture is including trunk flexion or bending forward, or also a fall onto the bottom. That's most commonly causing a compression fracture. So here's just a section of vertebrae. And on the left, you can see this nicely developed matrix of mineralization through the trabeculae is what it's called. And then to the right, we can see more of an osteoporotic slide. You can truly see right through the section, and the bone truly looks eaten away. So we'll talk further about the mechanism. So the gold standard for bone density is going to be a bone density scan for the hip and for the spine. Now, the spine is taken of the lumbar spine, the scan is. However, these bones are not typically the first bones to fracture. The bones that are most likely to fracture are in the upper thoracic region. However, they have to do the scan on the lumbar spine because the ribs, if the test was done in the thoracic spine, the ribs would skew the test results. So this is really the most accurate place. If we find that there is osteoporosis within the lumbar, they just assume that it's going to be higher up as well. And here is, again, that hip, I think it's Ward's angle or Ward's triangle, where we find that common fracture place. So they do that preventative screen there. The diagnostic criteria was developed by the World Health Organization. And here, this bell-shaped curve is just very nice visual. So here we just see standard deviations above and below the standard mean. And we're looking at bone mineral concentration here of the young, healthy adult, basically. And this lavender area right through here is osteopenia. And then this little tail down here, this little purple pink color, is going to be the osteoporosis. So, which is going to be a score of negative 2.5 below the average. And then severe osteoporosis is going to be negative 2.5 with a current fracture. So at this point in time, people, they might panic. I see lots of people who either come to other lectures I hold and they're not sure what to do. So the idea here is, how do we land on our feet? How do we take this and just roll with the ball here? There is a three-pronged approach for treatment, and exercise, medication, and diet. Now, I don't know, it was probably 18 years ago when I first was interested in this topic. And exercise was pretty much all that physical therapists really learned about. Strengthening, posture, stretching, and these are very, very important, don't get me wrong. I think during that 3-day course, there were 1 or 2 slides on diet. One of them was on vitamin D, and I think the other one basically said, eat your vegetables. So there wasn't really a lot known at that time. And medication, this is where your MD comes in place. I mean, having some conversations, also talking to pharmacists if you've got further questions. Those are people that you really can rely on to answer questions. So we'll go through all 3 of these today and hopefully open some areas of discussion or open our eyes about some of what we can do to try to feel empowered truly and maximize that 30 to 40% of influence that we have on this condition. So medications, hormone replacement therapy was something that, I don't know, I guess it kind of came into vogue for a while. I think it's probably lost some popularity. The progesterone molecule in our bodies is right over here. The synthetic progestin molecule is right over here. And again, I'm not a pharmacist and I'm certainly not an organic chemist. As I've listened to many lectures from doctors, they did like the idea of using progesterone molecules that are bioidentical, just to manage and reduce side effects. So this is an opportunity for women. Estrogen and progesterone are delivered together, as I understand. Now, these obviously are not used in the case of breast cancer history, but there is a chance of having a 5 to 6% increase in bone density, relatively. So hormonal characteristics. Progesterone is unique in that it actually can decrease estrogen sensitivity. There is a downgrade mechanism that happens at the receptor site. Estrogen will have an increase in sensitivity. As far as the bone cells themselves, progesterone has a positive impact on osteoblast activity, and osteoblasts are the cells that actually build bone. So progesterone is our youthful female hormone, makes us like our husbands and not want to eat our children. It makes us very youthful, and obviously supports our pregnancies too. So that is one way to look at how that might impact your bone. Estrogen is a hormone that actually increases osteoclast activity. And osteoclasts are bones that actually tear down or clean up our bones. Our bone cells die and they get renewed or recycled, so to speak. And as they are getting old, osteoclasts come and kind of tear down those old bone cells. So they will eliminate the oldest bone cells that are at the end of their cycle. Progesterone in general will decrease cancer cell production, and estrogen is something that increases cell production and can speed, obviously, cancer cell production as well. So again, but these are sensitive. Sometimes there are cancers that are sensitive to these 2 hormones, and so that can kind of put a spin on that whole system. Medications, other medications would be Fosamax and calcitonin, Vista Actonel, parathyroid hormone, and ipaflavone. So these are just some options, things to talk to your doctor about, or be able to look up, evaluate side effects. A lot of women I talk to overall, a good number of them are concerned about side effects. And so what I have to talk about further on with exercise and diet is really lifestyle changes are empowering for them, and it gives, we've seen some very nice results. So this is exciting news for them, but these are also very helpful as people start to go in and make those lifestyle changes. We're really looking to maximize that physiological environment to start producing bone. This is a book. I would highly recommend it to, honestly, anyone in the Northern Hemisphere or north of the Mason-Dixon line, for Northerners especially. This was, it's a great book about lifestyle and vitamin D, obviously, by Dr. Dowd. And what it does is it really focuses on all the uses and applications of vitamin D, what it can do for you, how to get it through UV rays, what you need to make vitamin D work, what kind of diet do I need to make vitamin D the most efficient, okay? Because there are situations where people can be vitamin D resistant, just like you might be insulin resistant. So this is I think a very helpful read. It could actually read too as a manual of just any mother who might have children, because really we saw that heredity being 60 to 70%. I think to some extent too, a lot of that does come with just what we eat, what we learn to eat from our parents. And I think that has a big effect. So this is something to consider. Upkeep, excuse me. I thought this was such a pretty picture. And when I thought about it, it really can go one of two ways. With excellent upkeep, this is the kind of image that will continue to look like this. Without upkeep, this picture will change dramatically. Without upkeep, we would see bits of algae floating in the pool. We might see a little bacterial kind of thing happening in the water. It would become murky and basically diseased, or multiple conditions in there that make it sick, essentially. So keeping that in mind, pH is important. So if we look at food as it's digested by the stomach and intestines and metabolized by the liver, as food is metabolized, byproducts are formed that are either acidic or alkaline. Think about our pool, okay? Think about what we might put into our pool. The body needs to be at a certain pH to function at optimal levels. So we're not really that different from that pool system, okay? That's our environment. So here we just have some pH sticks, basically. So optimal is going to be in here for the pool. It's pretty much right in there for us too, okay? We get into the acidic, and this is where inflammatory conditions begin. This is where cancer resides and becomes a problem. Okay, alkaline is going to be the thing to counterbalance that. And what is alkaline? Alkaline is buffers. Alkaline is calcium, potassium, magnesium. They all have those pluses on the end of them when we go back to that organic chem in the periodic chart. So buffers like that, calcium, like I said, potassium, magnesium, they're needed to bring the pH back into balance. These buffers improve the metabolic efficiency. And the reason why they do is if these buffers are not available from food, the body will take the buffers out of bone, muscle, and joints. So if I eat a cheeseburger that has starch, corn-fed beef, cheese, processed cheese, let's make it, and maybe a little vinegar and maybe some salt in there, sodium from a pickle maybe. I'm I'm going to need buffers, basically. Those are all acidic type foods, and I'll need buffers to counterbalance that. Okay, so if I don't have a salad along the side with that, my body has to find some way to balance that out. So an acidic pH will have a negative impact on the bone density, muscle function, and joint health because of how the buffers will just be basically leached out of the bone, muscle, and joints. So my question is, for anybody who has a condition that's associated with inflammation, i.e. osteoporosis being one of them, how efficient is your metabolism? And I think starting a food diary is a great way to start. Trying to find that balance. So basically we can take a lot of the strain off of the liver and basically using our food to create that balance or take the stress off of having to accommodate for the acidic food. So the balancing this, foods that lead to excessive acidity, salt, processed cheese and saturated fat, grain, sugar, cocoa, white vinegar, beer. These are some big naughties. Like these are the big ones. There's going to be a lot of other ones, but foods leading to alkalinity, sea salt. Now, sea salt's kind of an interesting addition to this list. There's another great researcher here, Russell Jaffe. He's getting known through kind of the research world for some research he's done on the food and chemical effects on acid-alkaline body chemical balance. And I've known people who know about his research and have followed it specifically for their osteoporosis and really had great results. So he wrote a kind of a little booklet, alkaline, I think it was acid alkaline balance. I think it's a small booklet, but it kind of reads like a cookbook, sort of. If you're sensitive to dairy, what you might replace with it. So other ways to decrease inflammation in your system. He also has a great chart, and you can find it all over the internet. There's a really nice image of it on beatcancer.org, and it's encouraged by them to improve alkalinity to obviously fight cancer diagnoses. So that's sea salt. That was not about, that's not from Dr. Dowd, that is from Russell Jaffe. But lentils, daikon, sweet potatoes, watermelon, raspberry, pineapple, lime, onion, these are all big hitters for balancing out your intake, basically. So how do we do this? How do we make the balance that we're talking about? Lean protein. Here, we're suggesting 25%, Dr. Dowd, and then the rest of your dinner plate right here should look like fresh produce of some kind, right? They really suggest greening up your meals. So if you have eggs in the morning, put your eggs on a salad. If you have some sort of meat at lunch, put it on a salad. That's one great way to really increase not only just the alkalinity of your diet, but then also getting valuable minerals, which you will need if you're, especially if you're looking to build bone. So the suggested ratio again is 3:1 of fresh produce to lean meat to promote that balance. Lean protein suggests grass-fed beef. Why grass-fed? Because it really is much higher in omegas. If you buy corn-fed beef, you're not going to get that omega or anti-inflammatory boost there. Pork, tenderloin, seafood, those high in omega, there's those omega fats again, and omega eggs all the way down here. Fresh produce refers to uncooked, unfrozen, and unprocessed vegetables and fruits. Why? Why do we want unfrozen and uncooked? Raw vegetables actually trigger greater enzymatic activity in your gut, essentially, and help break down the valuable nutrients of the vegetables. So raw is always going to be better, or at least a combination of raw and cooked is going to be a better combination where you will actually be able to absorb more nutrients. So this nutritional plan is suggested for conditions associated with vitamin D deficiencies like multiple sclerosis, osteoporosis, cancers, arthritis, cardiovascular disease, and autoimmune disorders. That's a lot of my patients. I mean, almost all my patients have something along this line. And I feel like this is something that truly anyone could be helpful with. Again, if they live in the Northern Hemisphere, if you've ever been vitamin D deficient, you know how it feels. It's really kind of a crummy, worn down state. So I really do recommend regular testing, and my doctor has never recommended it. I always have to ask. So the typical American diet leads to excessive acidity, just like that cheeseburger I talked about. And adjusting the nutritional habits can improve healing potential, muscle function, decrease risk of infection. This list goes on, and it even impacts gene expression and hormonal influences and cancer. So vitamin D, just a few quick facts. These are some of the biggies. Vitamin D levels of 20 or less decrease your body's ability to absorb calcium by 50%. So that's big. Those are the big minerals that we really, really look for to help balance everything out. And if your body can't even absorb it, then you're really in trouble. Ideal vitamin levels are between 50 and 70. People are rarely in between 50 and 70. That it takes significant supplementation to really reach those most often. You may not need additional calcium supplements if your diet is acid-base balanced and your levels are between 50 and 70. So that's kind of good news when people are concerned about taking calcium because they're worried about things like kidney stones, that sort of thing. Here's a comment about that. Kidney stones are due to acid excess in our diets that translate into acidic urine, which is high in calcium and primed for stone formation. So the cause is eating too few foods containing potassium and magnesium. Most Americans will eat 2 to 3 vegetables a day, 2 to 3 servings. What's really recommended is 6 to 8. And I know there are some statistics, I think 2/3 of American women are potassium deficient. I know my mother has to take potassium pills. I have her drinking coconut water to try to improve her absorption of potassium. So we need it for muscle function. And so cute side point there. So the clincher about vitamin D. Vitamin D builds bone. It's influential during the fetal and childhood development. However, when you're calcium deficient due to an acidic diet or lack of vitamin D, your activated vitamin D will work to disintegrate or break down your bone to mobilize minerals and raise blood levels of calcium in an effort to balance blood pH. So vitamin D is actually a bone modifier. It's not just a bone builder. So I could supplement with vitamin D, but if I'm not eating well, that vitamin D will actually take the minerals out of my bone, okay? So we need to have it to build bone, and it also fights cancer, vitamin D does. So we absolutely need it. It's responsible for about 300 different enzymatic activities, I think. So it really is critical. But if we don't eat to make the vitamin D work efficiently, we'll wind up actually losing density in our bone. So exercise is a big piece too, actually, of helping our posture or restoring our posture, gaining strength, balance. But it's not this hard, okay? It's not this difficult. Posture is going to be a critical factor, and it's going to be one of the early signs, actually, for a lot of women or men who have osteoporosis. We can see how the curves become accentuated. We can see how the chest becomes depressed. And once the chest becomes depressed, then the abdomen and the core are virtually absent, and they will not function. So what we want to do here is try to elevate, return the chest back to more of its upright position, and then all of a sudden the core will start to function better through here. Strength, we're going to be strengthening a lot of the glutes, the posterior structures of the spine, erector spinae, multifidi. Flexibility, we're going to be focusing mostly on chest, right? Quads, anterior structures, the pecs. Balance is critical because we have to really, we have to watch out for fall risk in many of the elderly. And then there's pain and other orthopedic issues that we have to consider. So these are some of the main areas that we're looking at when we have patients that come in with this particular diagnosis. Weight-bearing exercise, this is key. This is just absolutely necessary. So walk, walk, walk more. You want good mechanics, pretending that you're as tall as you can be, from head to tail, basically. And if you're already a really good walker and are walking daily, consider some walking sticks or a weighted vest to actually increase the resistance and challenge your walk to make more out of it. Get Wolf's Law involved, right? Challenging those muscles. Getting the upper thoracic spine with the walking sticks, and then the weighted vest for maybe people who are less than 113 pounds. They need to be weighing more and to actually make some compressive impact to stimulate appropriate bone growth. Lifestyle choices. Now, I threw some of this together here. It's kind of a hodgepodge, but they're different topics, different pieces, mostly lifestyle here, and some risk factors thrown into. So do please walk daily with good mechanics. Do eat your vegetables, right? Green up that meal, 6 to 8 servings. Eat potassium, calcium, and magnesium-rich foods. Supplement with your vitamin D3, right? The active form. This usually comes in an oil. That's how it is in its natural state. So that really is how we absorb it best. And when you're lifting, lift with a straight spine using a good squat technique. Laying down to take breaks from repeated stress. Bones will fatigue with multiple stresses. Okay, they will fatigue, and then what that means is then with the more applications, they're more likely to fail, excuse me. So bones do fatigue, they do get tired. Best to lay down and decompress the vertebrae, allowing the blood in there to basically bring in the oxygen and take some of the stress off, just temporarily, even 5 minutes. So much better than sitting, which will just only add compressive force. Hitting in the don't category here. Don't drink carbonated beverages. I had a patient call 3 weeks ago. What was it that she uses? Her Soda Stream, and she didn't know how did I get that? How did I get this? It just came out of the blue, really. Very small lady, uses carbonated beverages on a daily basis. So that was one. I mean, luckily we realized this. It was one big thing that she could take out of her lifestyle. Another option here, or another, drink alcohol. So please don't. Alcohol stops calcium absorption. So it's definitely something to use in a small amount and irregularly if possible. Eat metabolic stressing foods. So please don't eat sugar, cheese, table salt, and trans fats. Okay, those are all inflammatory. And please don't sit when your back feels tired. Not much is going to be accomplished by this, okay? It's better to lay down, get into that decompression position. It's kind of like, it's sort of like corpse if you're into yoga, or basically just laying on your back with your heels or knees bent if you like. Don't fry or grill food. These are both inflammatory. Frying is going to have that partially hydrogenated oils. Grilling is going to have that char. Both of these are inflammatory, and you'll find that those are on any anti-inflammatory food approach. Don't bend and twist with weight. For example, bowling or sit-ups. This adds too much compression, too much risk for fracture. And don't weigh less than 113 pounds if you can help it, okay? Your body needs enough weight, again, on the bones to stimulate some good bone growth. So thank you. I appreciate you all being here.
Thank you, Diane. And I just want to say thank you to all of our presenters, Dr. Hellman, Mike, and Diane. We really appreciate it. And I'm just going to kind of open it up if anybody has any questions right now. Otherwise, I will be sending out a email probably tomorrow with a link so that you can go back and watch things on from the link from the presentation if you so choose. So does anybody have questions for any of our presenters? And feel free to unmute yourself if you do and have a question.
Ollie, I don't know if you saw that one of the people that was watching, Risa, she had a question that she sent into the chat. I think it's geared toward Dr. Hellman. She's just wondering, and maybe this got answered for you, Risa, excuse me, what's recommended for women who have a total hysterectomy, who have had one? Risa, did that get answered for you? Is she still here?
No, she's not still on.
Okay, she had typed that in, so I don't know if that question got answered for her in regards to what she was talking about. But. Diane, I have a question for you. A wrist fracture is an early indicator of osteoporosis, or that you should get a bone density test following any wrist fracture. Is that for any age you're recommending that? I mean, I see so many young kids who have falls on outstretched arms and so forth. What were you referring to exactly there? Maybe I missed it.
I think I didn't exactly explain thoroughly, but I think the older set definitely. So whatever demographic groups in between 40 to 60, those are going to be more high risk. But I will say that if there are children that are found to have multiple fractures within a year, within a couple years, they should have a scan. Pediatric osteoporosis or juvenile, osteoporosis is a very real thing. I've seen it before in the clinic, and honestly, it is a big, I think a lot of it has to do with lifestyle. How picky of an eater is this kid, right? What kind of activity do they have? Are they sedentary? Are they getting out into the light? Do they have vitamin D? These are all kind of big lifestyle questions, and I think a lot of them can be prevented. As a mother, I was interested in this topic because my mother has osteoporosis. Her mother had osteoporosis. I have a food chart taped to my refrigerator. I had lots of fractures as a kid. I think some kids do. I want my children to have stronger bones than what I had. And I make broccoli a lot. So if I can, I really encourage people that when they hear this, if their grandmothers, tell their children, encourage grandchildren, start to have some different styles of eating. I used to have a little game that I played at the dinner table. It was the bragging game. I mean, how often do you really get to brag about yourself, right? So what we had was a competition. how many portions of vegetable or fruit did you have today? And we would go through, and we had like a little mini diary and we would just try to go through and remember each meal about what we ate. And then someone would win, and it was kind of like bragging rights for the night, but it was, I don't know, I guess we're competitive. But it was fun, and it made us go and have seconds of roasted vegetables or a little extra potato with skin on it, or I think I'm going to have a date with some almond butter in it and really get some high mineral content in my diet today. So I know that sounds silly, but for kids who just want to be better than their brother or sister, they always have that rivalry. My kids will eat a couple portions of spinach. I'm happy about that, So I just try to make sure that people see how this is. I definitely cook different than my mother did, partially because of what I've learned through over the years here. So I just hope that it passes down to other mothers, other children, other fathers who cook, and so forth.
Thank you.
Question for you, Diane, about the vitamin D. I thought I heard along the way to absorb vitamin D from the sun. You want to have your sunglasses off, right? No sunscreen for the first 10 minutes or something. What's the recommendation there?
Yeah, I think it's for the first 20 minutes or so.
20. Okay.
Yeah, because there's a certain your skin has a certain tolerance. Basically, we're not looking for sunburn here. We're looking for that kind of healthy glow, right? And then that's enough of the UV rays. So then you want to get into protected mode and put the sunscreen on. But the best time to get that would be at noon. And definitely there are other elements that are needed for vitamin D to be absorbed and function. So it needs omegas, okay? It needs omega-3s. And you can find that in cod liver oil and other foods too. Also vitamin A. Now, what I usually recommend is vitamin A can reach a toxicity level. So I recommend using a plain vitamin D3 supplement if you're supplementing, which I kind of hope people are, because we all drop down during the winter months. And it takes us all the way to the end of summer to catch up again. So I do recommend vitamin D3 for all people, again, all northerners essentially. And vitamin A is toxic. So I just try to say maybe a supplement, a daily vitamin that might have vitamin A in it, because you don't really want to overdo on that, right? So.
Okay. Thank you.
Yeah.
Quick comment to interject with Anne's question follow-up. So one thing to think about with teenage girls, however, is the female triad syndrome. So there are plenty of highly athletic females that are not nutritionally supplementing well enough, and as a result end up with low bone density, stress fractures in the shins, but also plausible if they did fall from what might seem like a simple fall, that they're more susceptible to fracturing because they are not supplementing enough with the number of calories that they're burning. And then Diane, real quick, just so I've been taking a sublingual D, and finally my Ds are in around 60, so they're finally where I'd like them to be.
Yeah, that's great.
Well, it is good. I'm just curious because I've tried all kinds of different ones, and I just wondered, is there enough research to substantiate that sublingual is better than anything else? Or maybe,
oh boy,
I mean, and I do take 5,000 IU a day, so maybe part of it is I never quite took as much as, I don't know. I'm just curious if you've read anything, because I have been telling more people just to do sublingual because it seems like it works, but I'm an N of 1, so that doesn't mean much.
But absorption is everything, right? I mean,
Yep.
that, and having it, there's lots of sublingual medications, right, for better absorption through sublingual. So that, I mean, to me, that makes sense. I haven't seen the research necessarily. And I have seen, there's even, I think, people who say that absorption, even with the supplements, isn't very good either. Right. But I think what most do agree on, though, is that daily supplementation, like you're doing with 5,000, is going to have a better accumulative absorption than if I dosed 50,000 one time a week.
Right.
So that 5,000 number seems to be something that we're hearing over and over again, that it's being recommended regularly. And
That's
essentially it's like a day at the beach.
Right.
Right. I mean,
True.
that's, yeah. Thank you.
Awesome. Good job. Great presentation.
Thanks.
Okay,
right, Molly.
well, if nobody else has any other questions, I just want to say thank you guys, everybody, for coming. And yeah, thanks so much. And if you have any questions, please feel free to reach out to any of the presenters tonight with your specific question. So thank you.
Thanks.
Thanks, everybody. Great job.